My name is Dr. Susan Rogers, and I am a general internist from Chicago, Illinois, and I'm president of Physicians for a National Health Program, which is a national organization of more than 24,000 doctors that advocates for a single-payer healthcare system. And I am also a proud beneficiary of traditional Medicare. The current threat to Medicare is very real. What we now call traditional Medicare was created in 1965 to provide a safety net for seniors and the disabled, many of whom lived in poverty, and to provide equity in health care when it effectively desegregated our nation's hospitals. Today, even though it is the most popular, effective, and efficient health program in our nation's history, traditional Medicare is at risk of being sold off to the highest bidder, with no input from seniors, health providers, or even members from Congress. Now, the privatization of Medicare began when Nixon enacted the HMO Act in 1973, and privatization actually exploded in 2003 with the creation of Medicare Advantage, the version of Medicare run by commercial insurers. The common thread among these privatization experiments is the theory that inserting a middleman between Medicare and its health providers, between physicians and patients, will somehow save money or improve care. However, it has failed at both. In fact, researchers estimate that Medicare overpaid Medicare Advantage insurers by more than $106 billion from 2010 through 2019, and that's money that could have been spent on seniors' care. Despite decades of failure, CMS launched a new model of Medicare privatization called the Direct Contracting. And instead of paying doctors directly, Medicare pays third-party middlemen called direct contracting entities, or DCEs, a set amount to manage seniors' health. DCEs are then allowed to pocket what they don't pay for in services, which is a dangerous financial incentive to restrict and ration seniors' health care. If you haven't heard of direct contracting, that's by design. It was created in 2019 by the CMS Innovation Center, also called CMMI, which is authorized to conduct payment experiments and scale them up to all of Medicare without input from Congress. Virtually any type of company can apply to be a DCE, including commercial insurers, venture capitalists, or physician groups. Seniors in traditional Medicare can be automatically assigned to a DCE without their knowledge or understanding if their primary care provider is affiliated with a DCE. Then the only way for a senior to opt out is to change primary care physicians, making this actually a bait and switch program for seniors. Forcing seniors to switch physicians is not only a terrible burden, but it undermines the importance of the patient-physician relationship that clearly DCEs don't acknowledge. The new model program that DCE middlemen will somehow lower costs and improve coordination of care. But former CMS and CMMI officials estimate that DCEs may spend as little as 60% of their Medicare payments on patient care, keeping the other 40% as profit and overhead. How this is an improvement on traditional Medicare, I don't know, since Medicare spends 98% of its funds on health care. As a physician, I understand that it is my duty and responsibility to help make the care decisions along with my patients and then coordinate that care. That role is not for investors to take from us. They do not coordinate care, they coordinate payment. Medicare was designed as a lifeline for American seniors and adults living with disability. We cannot let it become a playground for Wall Street investors. If middlemen in healthcare actually save money and improve outcomes, the U.S. wouldn't have the most expensive and ineffective healthcare system in the world. We don't need to put seniors through another failed experiment to prove this. So like an old African proverb says, if you keep doing what you've been doing, you'll keep getting what you already got. So we need to get back to what we know works, and that is traditional Medicare.